The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Peter Lee, Executive Director of the California Health Benefit Exchange, and welcome to a webinar to roll up our sleeves and talk about some of the issues with regard to qualified health plans. As many of you know, we began this discussion at last week's board meeting in Oakland. We recognize that the issues with regard to the selection, monitoring, holding to account qualified health plans are complex, meaty, and we wanted to make sure we had an opportunity to hear the range of opinions, views on these issues. And so we've scheduled 3 webinars. This is the first of the 3. Andrea will go through the other 2 in a moment. I want to just note a couple things as introduction, then I'll turn it over to Andrea, which is first a thank you to the more than 75 people who have joined this call, and I'm sure that more will be joining as we move along. We have a lot of interest in what we're doing. We appreciate your engagement in helping us do it right. Second, I want to note that at each of these calls, we will have and are having multiple board members present, able to participate, ask questions, to listen to your comments and feedback. On today's webinar, Diana Dooley and Paul Fear are able to join us. Paul and Diana, thank you very much for your ability to join us. And again, we will be, and Andrea will repeat this often, this is not the only time for input, to ask questions, etc. We very much look forward to you raising your comments, thoughts, and suggestions, both here, but also importantly in writing before August 6th. And with that, again, I'm going to let Andrea review the other webinars that are coming up later this week and next week and launch us into the material. The last thing I'd note, I believe the PowerPoints that we're going to walk through are posted on our website. So if you have technical difficulties and can't see the webinar, you can find them. They are slides you will be familiar with, what was already presented, but we'll use that as the framework for the discussion, and you can find those on the Exchange's website. With that, Andrea?
Thank you, Peter. Andrea. Well, first I'd like to announce the next 2 webinars. They're also posted on our website, all the slides are not on there yet. This Thursday from 4:30 to 6, we'll be discussing provider network issues that will include both network adequacy and the question of essential community provider standards. And then on Wednesday, August 1st, bright and early at 8:30 in the morning until 10, we'll be addressing quality and affordability issues related to QHP selection. Before we go to the slides, I would like to introduce and thank the team from PricewaterhouseCoopers who has been supporting the drafting of the brief and some of the heavy lifting behind the report. That includes Sandra Hunt, who is a panelist with us today, Susan Murphy, Emma Hu, Pete Davidson, and my team of Leah Morris and Amy Krause also contributed to the original report and will continue to have input.
One other note of housekeeping. We originally scheduled this call to be an hour long. We are ready to extend to an hour and a half, so you'll note that the time says until 6 o'clock, 4:30 to 6, which is an hour and a half. If you can't stay on, we're sorry, but we felt that so many issues may come up, we didn't want to truncate them in an hour. And so each of these 3 webinars will be 1 hour and a half. Again, if we're done early, hallelujah. If not, we're ready to keep on going.
Go home.
Okay? Right. And the other thing, I'll remind people that many of you have been on webinars before, if you want to speak, you need to raise your hand, and then we will identify and call on you and turn you off mute. Diana, Paul, Sandra are off mute, so they can ask questions and raise comments to you already. We will be going through this issue by issue, and we really encourage people to save their comments for issues they really want to talk about. We will be, again, going through a lot of issues, many of which we think are not that controversial, some which are. So with that, take it away, Andrea.
We're trying to get to the first slide here.
Just imagine that you're waiting in line to get into a board meeting right now, if you're wondering at the pause. There we go. First slide up. And I would remind everyone, as you know, that behind a slide is the 255-page plus set of recommendations that fleshes these out in more detail. And Andrea will often be referring to where this relates to the underlying report. So with that, Andrea.
263, but who's counting?
Yeah, there you go.
So the first area we're going to cover will look familiar to you, and this is on the question of what are the allowable basis for rating premium come 2014. And we've identified 5 areas: family, tier, age, geography, tobacco, and wellness, that are usable under the Affordable Care Act, and have some recommendations on each of those. And most of these are the same as you saw at the meeting last Thursday, but a couple of them are different. And so I'll say, just as by way of introduction to these, that we are expecting some of these, if not all of them, to be determined by either state law or by federal rules that have not yet been issued. So keep that in mind as you consider these. First, our family structure, and these are both combinations of types of families and ratios of premium that would be allowed between the different. So this is parent and child, 2 parents, 1 child, 2 parents, 2 child or more. That's what we mean by family tiers. And what we're recommending is that standardized family, cannot hear. Okay. Okay. So we're recommending that family tiers and the ratio between pricing on families be standardized both inside and outside the market. And let me say, as a threshold matter as well, that all of these rating factors should be standardized across the market. Okay.
Are there any comments on that? Otherwise, we're going to move on to the next issue. I think everyone has heard the importance of market standardization.
Moving to the slides. So the next rating factor that we considered was age factors, and the same question. The question was, should we standardize age bands, as well as the relationship between the premium ratio between age bands. We know that the Affordable Care Act allows no more or no less than a ratio of 3 to 1, but there's some flexibility within that. And the recommendation that we're making is option B, which is to standardize age factors for premium rate development by all issuers participating in the exchange, if not done by federal rules.
And I will note that one question that's come up is, do we expect federal guidance on age bands? And yes, we do expect federal guidance. We have not had definitive notes on would the guidance be defining what the age ranges are, or age ranges and factors within ranges. And that's one of the things of the scope of the guardrails is to be determined.
So any question on age bands and age factors?
So we have a question on how will age band rating interact with the child-only plans?
The child-only plans are not affected by age band at all. The child-only plans will be decided, I believe, based on the upper limit of what constitutes, what I think it's 21. Child-only plans can be up to 21.
Right. Okay. Let's go to geographic regions.
If there's any more age band questions. So moving to geographic regions, the issue here is, do you require issuers to cover the entire region for which they're licensed? Or do you allow issuers to come in and offer a product that covers less than the region in which they're licensed? And we settled on option C, is what we're recommending to the board, and that would require an issuer to cover the entire region. But if the exchange was going to be allowing an issuer who was licensed for less than a full region to come in for a sub-regional product, the statewide issuer or the region-wide issuer would be allowed to compete head-to-head with the sub-regional product.
So
that's it. Any questions on
or comments?
Or comments on the geographic region issue?
And I will note, we'll bounce back and forth a little bit. So there's been another question on the family structure, which is it a flat rate, or will there be a number of individuals in a family and an individual rate? And that's part of what we would standardize. Is a family, always 4 people? Are there 3 family tiers, et cetera? That's exactly the great example of the need to standardize. So some plans don't define families differently. Okay?
So that is exactly the issue. And then there's the question of we want it to be the same inside and outside of the exchange. So family bands, if you will, or family groupings will be fixed. Okay, moving on.
So everyone, I want to pause for a second on this entire geographic region issue, which is a very important issue, which is that this would, again, I just want to restate it because it's an important one, where a plan is licensed to be in all 5 counties. They would serve all 5 counties, but we would allow that plan to also offer a product that might be in 1 county in the 5 counties. So again, we want to allow innovation, allow plans to do, for instance, ACO networks, but also to assure that there's going to be statewide and region-wide coverage. So this issue of the sub-regional plan is designed to allow for instance, a Medi-Cal plan that is only licensed in 1 county to be in that county, but it might be the case that a statewide plan wants to compete, so to speak, head-to-head in that county alone, as well as serving other counties. So we have always anticipated to allow plans that are licensed in 1 county to only serve that county, but this would actually allow the more broad network plans to be in a more targeted area as well as serving the broad population.
And there are some plans that cover 1 county and part of another county, and that would apply in that situation too. So it looks like we have a question.
Address that one.
Okay. All right, let's move on to.
So would we require the sub-region product alongside a region product? And the answer to that is yes. If from a consumer perspective, if you live in Alameda County and have a product that is only in that county and a product that is offered through all 5 counties in that region, that consumer would be able to choose both wherever they are, all the products offered. So both the sub-regional and the region-wide product. Okay, let's go to the next.
Okay, so the next 2 issues are allowing rate adjustment for tobacco use in the absence of legislation and the wellness program. So let's take the issue of tobacco. One of the most important issues with respect to tobacco rating is this absolutely has to be the same inside and outside of the exchange. So we haven't actually gotten to the issue of the question of how we would achieve that. But as Peter said earlier, at an earlier webinar, we don't want the exchange to end up being smoker's heaven. And so we would need to work with the legislature or state regulators to figure out a mechanism for making sure that whatever the tobacco rating outcome is that it applies across the board. And what we're recommending in recognition of the position that we're in right now time-wise is that we conduct further research on the pros and cons of requiring a limited, for example, a 5% rate up for tobacco use by issuers. Now, in today's market, issuers are rating up for tobacco. We don't know how much, but this would be, again, standardized. Any questions on smoking? Rate up.
And again, we're going to ping pong a little bit because sometimes questions come up about older, prior issues, and I want to note again, back to the issue about family and age bands, is that the age bands that relate to families would have actually, the families, the children up to 21 would be part of the defined family groupings in family, standardizing family coverage.
Right.
Right. Okay.
Right.
So, and back up now to tobacco, and I just want to acknowledge that this is something that the board and the exchange are wrestling with a lot, is that, and I want to underscore what is in the background brief where there's actually a model of what it might mean to have a 5% smoking rate up for someone who is low income, we are quite concerned about the issue of not having a rate up discourage someone from actually enrolling in coverage. And a 5% rate up would mean an additional $30 a month premium for that individual. It is not subsidized by the federal government. Now, some have said that that $30 is only 3 packs of cigarettes, and is it enough of an incentive? But we're trying to, even in considering this, recognizing that having some incentive may be a positive thing, but we don't want that to be at the expense of discouraging enrollment. So there's a couple of comments. I'm going to read them. One from Sandra Barr, and I do want to remind people, we're a transparency organization, so we'll state your name. So know that when you say comments or questions, which we assume you all know. Sandra Barr notes that the 5% rate up for tobacco seems very low. And again, part of the reason it's low to even consider is we are concerned that a higher rate up would potentially decrease enrollment, because we know it's a price-sensitive market. A second question from Ellen Wu is, when do you anticipate making a decision about rate adjustment for tobacco use? Not at the next board meeting. We're still researching this and looking at this, but it would need to be as soon as as the September board meeting to look into this. So it's probably September's board meeting, I would guess. Another question: can the rate up be scaled based on MAGI, which is the adjusted gross income, and have an income-adjusted rate up? And it's a very good comment. Some have said higher income people, if you're at 400% of poverty or 500% of poverty, could have a higher rate up. That's something that we could look at. It's a good suggestion. It's a piece we've looked at, but it gets quite complex. One of the other things that I would encourage and remind that if any of the panelists or board members care to speak, they are welcome to do so and ask questions or comments, or add comments as we go along. So jump in if you care to. So another question now. This is on a region, sub-region issue. Again, I apologize that we ping-pong around a little bit, but the question here is on an entire area versus a sub-region. If we have persons who migrate between sub-regions, as they may be the case in agriculture or construction, will a person potentially need to change plan if moving from one sub-region to another under a sub-regional model? And it's a good question, and just to remind folks that this is an issue generally, is that people will be enrolling in plans that are specific to their county or otherwise their residents, and if they end up moving to entirely different areas, forget sub-regions, across rating regions, it may have effects on their premium. Isn't that right?
Well, I mean, moving is one thing. If you're, I'm not sure if the questioner is asking about if you move to a different area, then you do have to enroll in another plan. There are sub-regional plans today. For example, Sharp has a plan down in San Diego. Western Health Advantage has a plan. And anybody who's in those plans today, if you actually change your zip code and you move to another geographic region, you do need to enroll in a completely different plan. However, if you are living in that subregion and you decide to consume care outside the boundaries of the subregion that is covered by your policy, then the out-of-area rules, whatever they are in your policy, would apply just as they would today.
So let me note a couple other comments that relate to smoking. And one is from Edward Marino. What if rather than rate up for tobacco, you applied a higher deductible? This would keep premiums the same and not deter a smoker from acquiring insurance. I think it's something we can certainly look at. I think part of the concern is that it loses the incentive effect of encouraging people to stop smoking. And I would encourage people, in the material we provided in the background briefs are 6 or 7 references to material on tobacco cessation, etc. including in particular a randomized control study that was published in the New England Journal in 2009 that noted that incentives in the $200 a year general amount, which is similar to the $30 on a monthly basis, actually resulted in a 15% smoking cessation among smokers. That's a lot of smokers stopping smoking, but it's because there's a felt financial incentive. I think the concern that we'd have with changing the deductible is most people don't use health care every year, which is a good thing, but it means that the incentive wouldn't be felt to have the effect that it's sought to of encouraging people to stop smoking.
Right, because tying an incentive for a change in behavior to deductible requires using healthcare services in order to get the benefit of that, as opposed to the study that Peter was citing, where people went through a smoking cessation program, received cash. If they were still off cigarettes 6 months later, they received more cash, and if they were off cigarettes a year later, they received a third amount of cash. And that did produce a 50% reduction in smoking. The question about rating tiers. Can carriers offer rate tiers the way they want, like 3-tier, 4-tier, or PMPM? I'm not sure I fully understand the question, but rating tiers, premium is going to be allowed to vary by geographic region, age, and family tier, and that's it.
So let's actually,
now, price will vary from product to product. I think if that's what you're asking, there'll be narrow network products, broad network products. So price will vary from product to product.
Peter?
Yes?
Peter, this is Diana. Thank you. I had a couple of questions earlier, but I was on mute for some reason. But I have a question to the tobacco, and it will be the same for the wellness when you get to that. And it relates to the timing of the of when the Exchange Board will make its decision vis-a-vis the bills that are in the legislature, and whether or not this goes back to what came up at the last board meeting about the impact on the market outside of the exchange. I believe that the legislation that's being considered would put the same restrictions on all insurers, whether they're in the exchange or not. I wondered what your thinking is about that with regard to legislation versus the authority and action by the Exchange Board.
It's a great question, Dan. I think that my thinking is, and this relates not just to smoking, but also to the issues with regard to standardization of age bands, of family structures, et cetera, that my suggestion is that the board would make action that is contingent upon there not being state or federal action that would supersede this, and we might even make a statement which we would encourage. So the issue of, for instance, again, this relates to tobacco, but very much to these other issues where we want market-wide standardization, we need it, we can't make it happen, and what we can do is affect what is likely to be 80% of the individual market of plans that are in the exchange and offering products outside of the exchange. So I think that's what I would suggest, Diana, but I'd welcome your thoughts on that. Okay.
Okay, so we have a good question.
The question relates to wellness, though. Let's go to the note on what the wellness.
Well, I do, but I want to answer the question. We have a good question on the interrelationship between tobacco rating and the wellness incentive, and we will be discussing wellness incentive in a minute. But let me clarify that should there be a statewide rule allowing or disallowing, let's just say allowing, some amount of tobacco rate up across the board in the market, that happens at the time of enrollment. And I do want to say that I overlooked one very important part of our recommendation. So this is at the time of enrollment. This is not at the time of a wellness program being offered, which is during the plan year. So if someone is a smoker now, they could sign up for a smoking cessation program upon enrollment, and the issuer would be required to waive the 5% rate up. Okay, so let's go to wellness.
I actually want to go to one of the other issues about the suggestion of deductibles being affected by smoking and wellness. There's also the concern that our expert counsel at PwC have noted might be problematic because it would change the actuarial value of plans. And so we've got a lot of moving parts we need to be thinking about. And if you were to change deductibles, depending on how much you change them, it could affect actuarial values. Okay, so let's go to the next element of this area on wellness program.
Okay, so we did a little bit of research. We got some very helpful consumer input and question about what our legal authority is under the Affordable Care Act to recommend wellness program incentives, and we went back and re-looked at the law and discovered that our original recommendation, which is to allow employers to implement wellness program incentives to encourage participation and achievement of health-related targets, is well within the law. But it is limited at this time to shops. And so that will be for small employers, the small employer market. And the Affordable Care Act is envisioning a 10-state pilot or demonstration program to be occurring to test the same wellness incentives that we'll be discussing for the shop in the individual market, and they'll be and we'll be commenting on that later on in the webinar today and seeking your input on that. But on the wellness program incentives for shop, we are recommending that wellness program incentives be allowed for the shop. Okay, that is the last issue on rating issues. So before we leave premium rating issues, let's see if we have any more comments, keeping in mind that a big part of the webinar is not only so we can hear from you, but so you can hear from each other as well. I can't read the top one.
So the top one we've addressed. So the next one is that given the earlier question on rating tiers being allowed, likely reflects concern that the current market practice of rating tiers based on health status and claims experience. And this is absolutely the case that today there are rate bands. There can be different rating premiums for Tier 1 enrollees are often less than Tier 2 because of health status. And it is important to understand and be clear that effective 2014, there cannot be rating tiers of any variety based on health status in the market, neither the exchange market nor outside of the exchange market. And thank you, Deborah Kelch, for that issue. So with the issue on wellness, we're going to come back to the wellness issue broadly. So Beth, hold on. We're coming back to wellness?
We are.
Yeah.
But in promoting wellness and prevention.
Great. So we're going to come at it today, right?
Yes.
Great. Okay.
Okay. So now we're moving on to plan design.
And we have someone up who wants to actually try to have a question verbally. So we're going to try to unmute Van Lee. Van, can you hear us? Van, speak, please. Van?
Hello, can you hear me?
Yes, we can. You're on live. Go ahead.
You know what? You answered my question earlier already. So
we did.
Yeah.
Well, it's great to hear your voice. Thank you very much, Van. Talk to you later. Okay.
Okay. So there are one. What happened to my slide? Here we go. Okay. So there are 5 issues on the question of plan design standardization, and one is cost sharing provisions, and the option of whether we should have what I call the free-for-all, no standardization of cost sharing versus some standardization versus very strict standardization. And the staff is recommending to the board that we standardize the major cost sharing components of benefit plans but allow limited customization. And the facial advantage of this is it makes shopping by consumers and comparing plans in their region much, much simpler if the deductibles, the annual out-of-pocket, and the copays are all the same by metal tier. So that we have proposed some specific plan designs, and we're going to take a little bit of time to go over those today. But we've also had a question about, well, you say you're allowing some limited customization. What does that really mean? And is that an open door for background underwriting, which of course we don't want? And I'm going to ask Sandy Hunt if she can give us some examples of the kind of customization of benefits that would be allowable under this particular recommendation.
Sure. Basically what we're talking about is some customization around some of the ancillary benefits. There will be a floor, for example, once the essential benefit plan is clearly established in law, but there will be the opportunity if plans choose to add on to some of those ancillary benefits, things like some of the therapies and other items where there are typically limits on the numbers of benefits that are allowed under the plan. But all of the core components, as Andrea said, the deductible, major areas of cost sharing, co-insurance, co-pays, those will all be standardized. The one place that there's some additional opportunity for some customization is in the thinking around value-based benefit plans, and where there are incentives put in place for consumers to use particular providers where there's some best practices in place.
And just to follow up on that, thank you, Sandy, just to follow up on that, most of the value-based benefit plan designs center on high-value pharmacy, where people who are managing chronic illness, if there is a copay or repeated copays for drugs that people are taking all the time, some studies have shown that even a waiver or a reduction in those pharmaceutical copays increases compliance and therefore results in better patient management of chronic conditions. So that would be a specific example of the type of value-based benefit design that we would allow. But certainly we'll be looking for some, I mean, we are truly looking for some innovation and commitment to help people manage chronic conditions by allowing value-based benefit plan design. Where we'll have to be vigilant is that we don't want plan modifications that are basically designed to favor or disfavor certain types of risk selection.
So I'm going to now, if I could, turn to some of the comments and questions we've received. And the first will be jumping back a little bit to the issue of age rating, which is if insurance carrier A can treat 30-year-olds more cost-effectively while carrier B treats 40-year-olds more cost-effectively, they would have to price those ages the same if we had our standardized pricing ratios between them. Without age rating restrictions, carrier A would price 30-year-olds cheaper, carrier B would price 40-year-olds cheaper. Wouldn't that be better for consumers? And I think this really is a very good comment. The issues around standardization eliminates gaming, which happens a lot in insurance and a lot of under the lack of clarity on how pricing are set up, but it does have an impact of reining in either some innovation or some pricing that may make sense otherwise. So it's a good point, I think, worth us thinking about generally. Next, coming specifically to the issue of plan design standardization, and this is a question from Beth Capel, of does this trigger the provisions in California law on standardization of products in the outside market? And just so people understand, this provision is one that says if the exchange chooses to standardize, then non-exchange carriers need to offer the standardized products as well as whatever else they offer. So I want to be very clear what that means is if Plan A is not in the exchange at all, and the exchange says we are standardizing benefits, then Plan A has to offer a product with that standardized benefit design. They can still offer dozens of other products, but they must offer that product.
Under the California ACA.
Under the California ACA.
But if the questioner is asking what happens to all the non-exchange products that could be offered by non-QHP issuers?
This is a non-QHP issue. I think that quite honestly, if Sandy knows, I think we aren't sure on this. I'll be
I believe that if standardized benefit plans, at least our interpretation is that it would, in fact, we would need Gary to do that legal analysis, but that it would, in fact, trigger that requirement that those plan designs would also be offered in the outside market.
And again, that's our sort of our working assumption is that it would trigger that. because even though it's not 100% standardized, it is close to that. And so the intent of the legislature is that if the exchange has standardized products, then consumers should be able to compare non-exchange carriers offering the same product. And so that is, and we need to do further research on that, but it's a great example of where the exchange has effects on non-exchange products in the market.
I agree. What I was referring to was they do have to offer that particular plan design, but they're not limited to that. That's all I was saying.
Okay. So next question. What is meant by ancillary benefits?
I'll let Sandy answer that.
It would be, the ancillary benefits would be things other than your core hospital, inpatient, outpatient physician, prescription drugs. So it would be things like physical therapy, occupational therapy, the things that make up a smaller portion of the healthcare budget. And again, excluding those core hospital physician drug categories.
So next question / comment, and this is from John Ramey. Thank you, John. Has staff considered that the less standardization there is in rates and cost sharing, the less capacity consumers have to make apples-to-apples comparisons of health plans? And the inverse of that is the more standardization there is, the more apples-to-apples comparisons consumers can make. And I think John's reason that we're seeking to walk that middle line of having enough standardization so it facilitates informed consumer choice as much as possible, but not, and again, having a band of allowing for some innovation that consumers can understand where that is and what that means. But I think it's John's raising a very good point. It is standardization is the servant of consumer choice on one hand by being informed you compare apples to apples, but it does have the danger of dampening innovation and having a broader range of choice.
Right. And there's another question. Are we concerned that the exchange will be home of the insured that would otherwise fall under what has been known as adverse selection? I don't think so. The studies that have been done by UCLA for us have not proven that concern to have any validity at this point. Part of the protection of the California ACA, as Peter noted earlier, is that every single plan that is plan design that is offered in the exchange, that those plan designs have to be offered by any carrier outside the exchange, whether or not they are ending up as a QHP issuer or not. So the same plan designs inside the exchange will also be offered outside the exchange.
That said, the exchange is indeed worried about, in the entire individual market, making sure as many people across the health spectrum are in, having a good risk pool of the entire individual market is something that benefits the exchange, benefits the entire market.
And I would say a further answer to that question is this is one of the reasons why we keep saying over and over again that all the rating issues, age, geography, tobacco use, and age banding need to be standardized both inside and outside the market.
We have a comment from Patrick Pine. Be cautious with requests to add complexity. All of this will need to be installed with training, communicated, will add time to the communication process. It is a tough balancing act. That was a quote. We agree. It is a tough balancing act. And the issues of making things simpler is good for administration, is often good for consumers, but it is walking that balancing act of some complexity actually provides for consumer choice and sensitivity to different plan benefit designs, et cetera. Okay. We have a question or a comment from a question from Kirk Andrews. How would standardization of cost-sharing components impact high-deductible health plans or health spending account eligible plans?
You know, I don't think it would actually have any impact. You still have to have the deductible high enough in order to be eligible to offer a health savings account with that plan. I don't think the standardization of cost sharing will have any impact, except obviously there will be some standardized cost share plans that will feature deductibles that are not high enough to qualify as an HDHP.
And I will remind everyone that under the Affordable Care Act in California, catastrophic plans are only offerable by plans that are in the exchange. They can offer outside the exchange as well, but what are today's high deductible health plans are apt to be tomorrow's catastrophic plans with, again, rules around essential health benefits, et cetera. We have Ann Donnelly, who's ready to ask a question verbally. Thank you for being brave, Ann. Can you hear us? Ann?
I cannot.
Yes, you can. We can hear you. We could hear you. Now we can't. So close and yet so far. Well, we could hear Ann. We'll go back to the printed text questions. So this is from Micah Weinberg. Does the California law not say that outside carriers must offer only one standardized plan per actuarial tier? And I think that is correct.
Yeah.
So it would be within each tier one standardized plan. They wouldn't have to offer multiple. So I think that's correct.
That's true.
Great.
But the thing is, the question is, it doesn't bar them from offering other plans in addition to the one standardized plan per tier that is offered through the exchange.
We have a question from Bill Worley with Kaiser. Can plans offer value-based benefit designs without limit in terms of the number of variations? How will we avoid this becoming the exception that swallows the standard cost-sharing rule?
Well, I think that's a very good question, and actually what I thought you were going to ask is how would we measure the impact on actuarial value? And we don't really know the impact on actuarial value until the end of the year when you look at the average amount the enrollees have paid versus the plan. I think that in the QHP selection process, we're going to have to be very convinced by the bidder that the value-based benefit plan design is not swallowing up the rule. So that will be, frankly, a job for the reviewers to make sure that the issuer is not trying to game the system, so to speak. And I think we're going to be very selective about the types of value-based benefits plan designs to make sure that we're really getting high-value approaches.
And I would be so bold as to say we will be tough, to quote Bill Worley. With that, we're going to try back to Ann on the phone. Oh, she dropped off. Okay, we won't drop back to Ann.
Okay.
Okay, we're going to go now to the next section. And I will note again, we're Ann. Ann, we can hear you. Ann, speak, please.
Thank you so much. I apologize for being very confused by this asking of the questions. I'm sorry. Thank you so much for doing this. I had one question in terms of the cost-sharing standardization. I wondered if the board had considered any protections for people with chronic conditions who are facing the need for drugs, which are typically tiered very high in specialty classes, making them often unaffordable for people, especially in the early part of their benefit before they've gotten some protection from the out-of-pocket cost protections.
I don't think we have considered that specifically. It's the kind of comment we very much welcome. In many ways, that goes to issues, I would suggest, of the specifics of the benefit designs that we're going to get to in a moment, how to make sure the benefit designs do what we want, which is encourage people to get the right care, right time. Andrea, would you?
I think we could certainly do some more thinking on that, Ann, but I'd say that we did do a little bit, and we're going to be, if you flip through the webinar slides, you see that one thing that we did was we pulled the standardized benefit plan descriptions that we're proposing, and you'll see many of them have a deductible on brands that is limited to, say, $250 in some cases.
Actually, we're coming to those slides in a moment. We have to highlight some of those issues when we get to
Thank
What
you.
I would say is the protection that you're asking about would be in the form of a brand-specific deductible.
That makes a lot of sense. Thank you very much.
That's great, Ann. Thank you. And I want to go to a comment from Ezekiel Chang regarding the age slope standardization. This again relates to the standardization of age bands. Will the age slope of standardized off exchange as well? And I just want to reinforce this again and again. We cannot say it too many times that the exchange can standardize within the exchange we believe we can and want to engage our health plan partners through contract, standardize what issuers in the exchange do outside of the exchange, even on non-qualified health plan products. However, the exchange cannot standardize for plans that are not, or set standards for plans that are not in the exchange, by and large. That requires legislation or federal action, and either of those are important things that we're looking at doing. But it is, we all agree, he says somewhat royally, that standardization needs to be market-wide. The exchange can do what it can do, and it will do that, and where we recommend it to the board that it do that where it can. But it's, there's other actions that need to be taken to make sure it's market-wide. Still on cost sharing, will standardized cost share and plan designs allow for varied network benefit tiering? This would seem to require unique designs to tie to the unique networks a carrier may have available. This is from Tony Allen.
So standardized cost sharing does not engage with a network. And the network offering can be, you can have a narrow network or a broad network with the same standardized cost sharing. And they would just apply, you would just have fewer choices on a narrow network offering. But the standardized cost sharing and the plan designs would be the same, regardless of whether it was a narrow network or a broad network offering.
So we're going to go to the next slide and continue on issues of plan design standardization.
I need to pick it up a little bit. Yep. So the next recommendation is to standardize benefit exclusions and limits. And we're recommending that we standardize the major benefit limits and exclusions, but allow for limited customization. And this, the actual implementation of this recommendation, should the board decide to adopt it, will interface pretty heavily with the essential health benefits definition that we expect the state legislature to be coming up with, and whether the essential health benefits by benefit category is limited to certain visit limits, for example, for certain benefit categories. But the reason that we're doing this again is goes back to the rule that we want the plans to be as comparable as possible for the consumers, so that when they pick a plan, they're basing it on the quality of the providers, the quality of the customer service, and price. And those are the three major areas where we're hoping, with everything as much as possible being standardized, carriers will be able to compete. So then we'll move on to the next one, which is standardization of drug formularies. And we are recommending similarity to the Medicare Part B minimum requirement that there be at least 2 drugs per class or category, as opposed to allowing carriers to only offer 1 drug per class or category. One question has come up since we made this recommendation, and that is we need to confirm that this requirement would not violate the essential health benefits. And I believe that we'll be contacting our legislative experts on that to see what they, if they believe that the essential health benefit rules would be violated on that. The obvious advantage to consumers in this case is if you only require coverage of 1 drug per class or category, that could be the drug that you as an individual have a bad reaction to. And if you don't have at least 1 other alternative to try within that same category, you might be forced into an out-of-network pharmacy benefit.
And there's one question from Ann Sawyer, is how different is this from what it is today? And the answer is it depends. There are absolutely formularies that do exactly this in the market today, and there are formularies that do not. And so one of the questions of reviewing where the state of California is in selecting what is an essential health benefit is, does it do that or not, and what would the implications be for us if it did not? So there are many plan offerings that do this today, and that's one of the things that we think appears to be a good practice that we'd want to look at.
Okay. So Ann Malone has a question on standardizing benefits. Is it true that each carrier can offer 2 to 3 plan designs per metal tier? And if so, are you saying that you are going to tell us exactly what each of these plan designs has to be for the major components? And the answer to that is yes.
How's that for clarity? So
Rare.
we're going to get in a moment to some of the details on plan design structures, but it is the anticipation that issuers, also known as plans, would want to offer in a particular area 2 or 3 designs. Some might vary by being a narrow network versus broad network, other by a variance in terms of how they structure the benefits specifically offered.
So I wanted to just go to the last 2 issues in this area, and then we can kind of see if there's any questions or comments on the whole issue of standardizing plan design on these elements. So with respect to value-based benefit design in the context of standardization, we've talked about this a little bit in terms of the customization question. And then the more specific question comes up then, what kind of value-based benefit designs would you allow? And there are kind of 2 kinds at each end of the spectrum. One type of value-based benefit design is, I would say, more punitive and is designed to lower utilization of lower value healthcare services, and that would end up in charging the customer who wanted to use those so-called low-value services. They would pay more out of pocket under that type of value-based benefit design. On the other end of the spectrum is the example I gave, where there are certain very effective drugs for management of chronic care conditions that some issuers have tried waiving as part of a value-based benefit design to reduce any type of financial barrier to drug compliance. And in many of those studies, they have shown that by lowering the patient's out-of-pocket costs, even below what they would be allowed to charge in terms of copays, results in higher compliance and therefore better patient management. So we are, with that spectrum in mind, we are recommending option B, which allows value-based benefit designs that lower patient out-of-pocket costs or provide financial rewards. And that's our recommendation on the types of value-based benefit designs that we would be looking upon favorably. Lastly, do you want to?
No, actually, what I'm going to do before we take comments, go through the next 3 slides or so, because I do want to be mindful of the time, and there are other issues we want to get to.
Plan design.
Right, then we'll get to wellness. Okay, so go through the plan design.
So then we're going to do pretty explicit.
So, okay, so let's go through the plan design.
Okay, so the last issue in plan design is a little bit tricky, but we are recommending that through our contracting ability with QHP issuers, that we encourage them to attempt to gain agreement from their network providers, that should those network providers be out-of-network providers for some other plan and be in a balanced billing situation with a TPO customer who is using them on an out-of-network basis, that those providers would agree to cap their charge essentially at some amount, say 200 to 300% of Medicare. Okay, so that's it on plan design for the moment. Before we move on to premium subsidies and cost-sharing reductions, let's see if we can take some questions and comments and engage.
So first on this is, would you expect that a 2-drug design would allow a plan to apply step edits to encourage use of one drug before trying the second drug? I think that's a good detailed question. The answer is probably yes. The issue is having both in, but is there a way to preferentially encourage people to try one that makes sure they can get access to another? But we'd welcome comments on the value of allowing quote-unquote step edits or incentives to use one of the 2 available in a class first. Is that fair, Andrea?
Yeah, I think that's probably, that's a very good question, but that's probably the level of micromanagement of a plan that would not be wise for the exchange to get into, but we'd certainly welcome comments on that. I would be hoping that if a plan had that approach, they would have some clinical evidence for preferring one drug over another.
Great. So there's a question generally, how will the state exchange plans relate to the federal exchange, or is it yet to be determined? And this is a great question. It actually reflects some of the, if I may be so bold, I'm not putting Patrick on the spot, general misunderstanding of how exchanges will work. In California, there will be one exchange, a state-based exchange that we're establishing. There will not be a federal exchange in California, assuming all the good work we are doing goes as we think it is. Other states that have not established state-based exchanges will offer federal exchanges. But it's an either-or issue. You will either be in a state that says, we're stepping up to be state-based, as California, with a lot of leadership from around the state, has said we're going to do, or states are saying either they aren't ready or don't want to be ready, we'll have a federal exchange. So there are interplay issues between a federal exchange and a state-based exchange. So it's a good level-setting question. I think people often don't understand that.
So I'd like to invite Christine Top to make, she wants to make a comment on value-based benefit design.
She needs to raise her hand, and then she will get her unmuted control. So if people want to make verbal comments, and we have Christine, who is now going to be taken off mute. Christine, go ahead.
Great. Thank you, Peter and Andrea. I just wanted to contribute the NCQA support of the exchange's desire to promote value and innovation. NCQA has been considering adding something along the lines of an innovation element to our current health plan accreditation program, and has decided to actually create a separate value and delivery system innovation program that will be released next summer. And we're very interested in having the input of the exchange in the development of that program, which we see down the line as something that could potentially be added into the program, but for the immediate future would be kind of a separate evaluation that could be added on by plans. Thank you.
Great, thank you, Christine. I want to go to a question from Beth Patel, which I feel is almost a softball, but not quite, which is, will you use evidence-based approach to value-based benefit designs and monitor impacts? And absolutely, we appreciate the question, is we will use an evidence-based approach on two levels. First, in reviewing what plans submit to us to see is there enough evidence to say it's worth being on the menu, so to speak. And second, we will absolutely be monitoring what it means to enrollees who are in plans with value-based design. Does it have the desired effect of encouraging the right utilization, discouraging bad utilization? And so the issue of evidence, we think the exchange should both use evidence and help populate and make better evidence. So it's a great question, but for any of these areas, we look forward to having data to look at what it means for different populations based on ethnic, income level, education level, health status, etc. So we appreciate that question very much, Beth. From Ann Donnelly, did the board consider including the Medicare protection of the 6 protected drug classes that ensures that in those 6 classes, all or substantially all of the drugs must be on formulary and utilization management techniques such as step therapy or prior authorization are prohibited?
We have not considered that, but we will ask our consultants to take a look at that and make a recommendation to us.
And this is a great example, though, of sending comments in of, look at this, have you thought about that? We welcome and relish.
Right.
Okay.
So moving to a couple of questions on the standardized out-of-network benefits. I mean, let me answer Tony Allen's question. Assuming that standardizing out-of-network benefits would not require a plan to cover out-of-network benefits, that is correct. An EPO or an HMO with no out-of-network benefits would still be permitted, and the answer to that is yes. The out-of-network benefit plan problem is unique to PPOs, as far as I can tell. And it is true that when people buy a PPO, they usually are paying a little bit extra to be able to have out-of-network benefits. The problem has arisen in providers who refuse to join networks when they could, and people end up with out-of-network charges, and the patients end up getting caught in the middle between a plan that has a set fee schedule that has a very low reimbursement for out-of-network benefits. And that is certainly something that we can look at as we refine this particular recommendation in terms of what kind of review could we potentially do of PPO plans out-of-network payment policies.
So, and I want to be mindful of the time. It is 5:30, and we have a number of other issues to cover. And I know we've got 5 or 6 comments pending that I'm actually going to ask Andrea to move to the next section. We'll come back to comments. So for some of those commenters, hang on, and we expect to be able to get to you, but I want to make sure we cover the full range of material today.
So I only have one slide, and then I want to get into some charts and tables that our consultants prepared for us. And that I think will illustrate some of the concepts and where we're trying to go with the recommendation. So we have split up the Affordable Care Act treats two different income groups differently in terms of the type of subsidy that the federal government allows. One is for folks who are below 250% of federal poverty level, and those individuals are eligible for two types of subsidies: premium subsidy, which reduces their premium, and cost-sharing reduction, which increases the actuarial value of their plan by reducing or eliminating cost-sharing, which is their out-of-pocket costs. The second group that falls within the 250 to 400% of federal poverty level are only receiving a premium subsidy and are not receiving any cost-sharing reduction, which means when they buy a silver plan or a gold plan or a bronze plan, the actuarial value, their out-of-pocket, does not change. It is what it is. Whereas the individuals who are in the 250% or below group, their actuarial value changes quite a bit. So just to illustrate that, I want to turn to this chart, on the next page.
For those who are looking at this otherwise, it's on page 8.
So these are examples of the impact of cost-sharing reductions for members below 250% of federal poverty levels. And by the way, one area of thinking within the exchange right now, exchange staff, is to perhaps change that 250% to 200% of federal poverty level, because as you'll see, there's a very, very, very small reduction in cost sharing for people who fall between 200 and 250%. So going to the first category, looking at the right, the individuals who are between 100 and 150%, when they buy a silver plan, that silver plan magically turns into a platinum plan. When you factor in the reduction in cost sharing, that plan has a 94% actuarial value. So they purchased the silver, but the cost sharing reductions only attach to the silver. But what they've actually purchased in reality is a platinum plan. Going to the group that falls within the income bracket of 150 to 200%, they're purchasing a silver where the cost sharing reductions apply, and they get basically an 87% actuarial value plan, which is pretty close to gold, but just by buying a silver. If those individuals bought any other plan other than a silver, they give up the cost-sharing reductions that are allowed by the Affordable Care Act. So let's take a look at what that would mean for two individuals. Now, here we have Joan and Jane. And I just want to go to the very bottom of this chart and highlight that Joan, who is an individual who is using just kind of an average use of healthcare services, with this when she buys the silver plan, after her tax credit, she would be paying, she would be paying the same in premium. She would be paying $672, but she would be paying $1,667 for the year as an average user of her cost-sharing expense. Whereas if she bought a gold plan and was an average user of healthcare, her out-of-pocket would soar to $3,500. Now let's take a look at Jane, who is a high user of healthcare services that particular year. Now she would be having, her cost sharing would be limited if she bought the silver plan, the same as Jones, to $1,667. Her premium is higher because she's at the 200% of federal poverty level.
And I should remind everyone that this is all about the issue of, does the exchange limit the choice of Jane and Joan to only a bronze or silver plan and not allow them to choose a plan that would be, in essence, a bad financial decision for them. And actually with that, I may ask Andrea to go to the next area, which is actually what I think people have more interest in. We welcome comments on this. It's a pretty technical issue, but it will make a difference for literally, probably in the neighborhood of 700,000 Californians are in this band, and we will help structure the decision about what we provide them, and we do welcome comments on this issue. If we could now turn to the standardized benefit.
Certainly.
This is now slide 10.
Okay. Well, for some reason we got the platinums and the golds. I put these in here just so you can take a look at the different approaches that we're considering. We will be having more than one standardized benefit plan per coverage tier in the interest of promoting consumer choice. So you can see that the variables, say just starting with the platinum plans, but also looking at the gold, what varies is the deductible, what varies is the out-of-pocket max. Some of the plans offer a per-day charge per hospital. Some offer co-pays for outpatient hospital versus co-insurance. One part that we have standardized across all of the coverage tiers is that the first 4 PCP visits are exempt from the deductible, and we would certainly welcome folks' reaction to that. When we did our focus groups earlier this year, a lot of people really placed a lot of value in those groups. They discussed that it was nice to know that if they had a low healthcare use in a given year, in addition to receiving their preventive care at no cost share, they could go to the doctor 3 or 4 times without digging into a big deductible. And that becomes especially important when you're looking at the lower actuarial plans like Silver. All of the Silver plans will have a deductible under this model, $500, $1,000, $1,500, or $750. The idea behind having different deductible plans is to give people choice and accommodate their tolerance for risk. People have very different tolerances for risk. The bronze plan, of course, is the lowest value plan in terms of how much the plan pays versus how much the patient pays, and of course will be commensurately cheaper in premium. And because it is a lower actual value, these plans need to have a higher deductible. We have a $2,000 deductible and a $3,000 deductible. And catastrophic is basically dictated by the Affordable Care Act, so that is the standard.
So let's pause here, and actually we could go back to the slide on Silver. Silver, in many ways, go back on the page, is sort of the center point. Remember, Silver is what frames what the subsidy is based on. Silver is what many say is equivalent to the standard employer-based coverage today. And one of the comments / questions made here that I would turn to Sandy and Andrea is, and this is from Beth Capel, is why the heavy reliance on co-insurance when opinion research indicates that co-insurance is very confusing to most Californians.
And I've had that discussion with Sandy, and she's great at discussing this, so I'm going to hand that over to her.
Sure. And of course, one of the reasons that Andrea pushed us so hard to come up with a plan design that had co-pays for primary care visits rather than co-insurance is really to address that issue. But the reality is, to get to the actuarial value of 70%, it's just very, very difficult to get there just with co-pays. And we certainly welcome input from the plan actuaries if they have some ideas about a combination of co-pays that would equally get there. For the key areas, most of them do have co-pays as a starting point, but getting to a 70% actuarial value, it just is hard to achieve.
And so one suggestion from Beth is, what about higher deductibles? And this is, again, where everything is a trade-off. Higher deductibles mean people get are hit more substantially up front, but generally co-insurance is confusing to people. They don't know what the percentages are. And this is exactly, again, what we did in framing these models was both seeing what's doable, but also looking what's in the market today in the quote-unquote best-selling plans and products. And we do welcome both consumer and plans review of these benefit designs. We want benefit designs that are understood to consumers and that are affordable and that we can offer. So we welcome more comments on this.
So in addition to Peter's comment that the trade-off for eliminating or reducing coinsurance, the trade-off is either you go to a higher deductible, which received a fairly unfavorable reaction when we did our deliberative discussion group with the Center for Healthcare Decisions, or you raise the copays. And people didn't like higher copays either. You'll see that the copays on the silvers, the lowest is 25, but they tend to be 30 or 40, and people perceive those as pretty significant copays. So if we sacrifice the coinsurance, we did try and put the coinsurance on the less often used services, but we would certainly welcome continuing comment on that.
So we have a question/comment from Bill Worley. Requiring 4 PCP visits exempt from deductible requires other cost sharing to be higher, which is the case. Higher deductibles, etc. Why 4 as opposed to 1 or 2? And I think that that's a great question. There's no hard science answer here. Having some visits exempt from deductible is something that consumers like a lot. Does it have to be 4? What's the value of 2? We welcome actuarial, consumer, and others' comments on exactly that topic.
And I guess my question is...
Yeah, please.
Go ahead. Peter, this is Diana. I'd like to just ask a broad question for you and all the staff to consider as you bring this back to the board. And it was prompted by someone said before about the complexity, and all of this coinsurance copay brings it more to my mind as well. I want to have through part of the filter how much of this we can simplify enough for people to understand, and where we have to make decisions for people by setting our values in place of theirs. And I mean that in that much of what I react to in some of the things that get presented is that we have to, that there's a suggestion that maybe we have to be parochial and make decisions for people that they can't make for themselves. And my own bias is to make it as simple as possible so that people can be well enough informed that they can make good decisions for themselves. But the deeper I get into it and try to understand it, I do think that we're going to have to make some value decisions that set the stage for people to make the decisions that we can explain in a way that they can understand. And so I don't know if my comment makes sense to you, but I'd like to see, from the staff a sense of, how we're making decisions that are foundational, that are underneath the decisions that people are going to see and make decisions for themselves.
Yeah, Diana, I think your comments and question to us is, to my mind, well understood and well framed. I think you're absolutely right that embedded in recommendations we make, to simplify things, to standardize, means applying certain values and choices. Another value could be, and there are products in the market that allow a consumer to vary every single one of these rows that you're seeing in these benefit designs, that literally allow a consumer to say, I want to have a co-insurance of this and a copay of that, and this, they get very complex. We are worried about making things that complex. But in doing that, we need to surface the values that are reflected in a particular benefit design, and we will work to do that and bring that back to the full board. So thank you for that, Diana. Okay. Now, in the interest of time, we've got 15 minutes, and there's a number of comments here that we'll come back to, but I want to get to through the balance of the other issues on wellness. And again, what we're doing in these discussions is not seeking to answer every question, but making sure that the broad community, which now has had almost 150 people on at different points in this call, understand what's here so we can get your thoughts, suggestions, refining as we go forward. So with that, if we could turn to the issue of wellness and prevention, and we'll get back to Beth's comment in a moment on that issue, and then we'll come back to the other comments that we've heard. Andrea?
Okay, there's basically about 4 issues in the topic of prevention. One is, how do we approach the use of the health risk assessment tool? And as most people know, this is kind of a screening tool, so information can begin to be gathered about the individuals who have enrolled in a particular plan. And we're recommending to the board that we not require that a health risk assessment be undergone at the time of enrollment, because we believe that would be a barrier to enrollment, and we're trying to keep barriers to enrollment to a bare minimum, and that instead we rely on the plans to figure out ways of encouraging their enrollees to use a health risk assessment tool, but not tie it to enrollment.
The thing I want to underscore, though, with that is we are, however, in the detailed proposal, intending to require that plans do offer a health risk assessment. And so this is a different of a member, an enrollee, does not need to take it, but as an important value so people can understand, here's where I'm at risk for, here's what I can learn from. We think it is an important tool that plans should offer, but we would not require that plans mandate its use, but that they would encourage it. So let's go on to the other wellness provisions. Then
right, so we didn't want to confuse folks by the word optional. We are going to require the health plans to offer a health risk assessment tool, but it will not be required that every single person who signed up for that health plan take it. So the next is the question of, should the exchange sponsor its own wellness program? And we looked at 3 options there, and at least for the time being, we are not recommending to the board that we get in the business of engaging an exchange-wide vendor to run a wellness program for everybody who has coverage through the exchange, but that instead we establish requirements for wellness programs and allow issuers to offer them. Now, what we have clarified since then is the issuers who are allowed to offer wellness programs that involve incentives are small group issuers only, not individual. And that also kind of leads us right into number 3, which is the use of financial incentives by plans to promote wellness. We have clarified that this is allowed for small group, and we are recommending that health plan issuers be allowed to use financial incentives, but again, that will be, at least under the Affordable Care Act, that will be limited to small group initially. So we will be revising these recommendations to reflect what we have. Oh, okay. We have 2 number 4s. To revisit this one, this is a recommendation that reflects our interest in having the exchange support and engage in larger public and community health issues that sometimes people see as separate from health insurance coverage, but we know that there's a link. And so in support of issuers and other public health efforts that are going on to improve community health broadly, we are recommending that the exchange engage in public and community health issues and encourage our issuers to do the same. And I apologize for the numbering glitch here, but we have a new recommendation with respect to wellness and prevention. And that is specifically that there is, in the Affordable Care Act, there is a provision for HHS to launch a 10-state wellness program demonstration project, which would take the wellness programs that are established for the small group market and test them in the individual market. And we're going to be suggesting to the board that California be prepared to apply to participate in the 10-state wellness program demonstration project, which according to the Affordable Care Act should be underway no later than July 1, 2014.
And the thing that I would note on this is that the scope, nature of such participation is that the issue of having well-structured, positive incentives for better health is something that we think is worth exploring, is worth encouraging, and we wouldn't do it until we saw what the terms of engagement were from the feds, so to speak. What does it mean to apply? But the issue that we are not doing this in the near term, because the law specifically notes that in the individual market it's not part of what's there, but we think the exchange should be ready and look actively at what it would mean to be one of the states that would do this right, to do wellness programs in a way that assess how they impacted different communities based on health status, income level, education level, et cetera. And so this is an area where in the near term we are not making an active recommendation until the feds come out with what the structure is for the demonstrations, which they have not yet come out with. So I'm going to, and I know we have a number of people who raised hands, and I'm going to, we have 10 more minutes, and we have one other set of issues that we need to get to that I'm just going to make sure that Andrea addresses, and then we'll come back to these to get people's comments. So let's go, if we could, to the last item.
The last issues have to do with supplemental benefits, and I'll say kind of at the get-go that we know that this is an area that needs clarification and a little bit more work. We kind of mix apples and oranges here between the supplemental benefits and the essential health benefits for pediatric dental and vision, and so we will be clarifying that. But we are going to be recommending that supplemental benefits be offered both in the shop exchange and in the individual market. And we're also going to be recommending that we accept bids from standalone dental plans for the pediatric dental benefit. We are going to need to work out some of the mechanics on how we accept those bids and pair them up with medical qualified health plans. And so some of the details of the execution on that need to be worked out, but that will give you kind of a general idea of where we're heading. And with that, I think we should use our last 10 minutes for questions and comments.
Great. And so we're going to go back to the questions here. This is a note earlier from Beth Capel on does this include wellness incentives based on achievement of health targets such as reduced hypertension, weight loss, blood sugar, and how's it different from ratings based on health status? And I think this is the issue that we'd be looking at the whole range of wellness incentives in the context of potentially participating in the wellness program demonstration projects in the individual market. And those can be either based on hitting targets, but I think in all ways we have looked at it so far at the exchange, it would never be based on targets alone. It would always be based on targets and or active participation in a program. So in a program to reduce weight, whether or not one succeeded, so it doesn't address just quote-unquote health status, but also addresses consumer engagement and activities that can be health promoting. We have move on down to the bottom.
If they don't lose weight. If they don't lose weight.
You're on the mic. David, you can speak too.
So if they don't lose weight, do they still get a financial incentive?
Yes, they do. Absolutely. If they do not lose weight but are participating in a weight reduction program, they absolutely still get the incentive.
Yes.
Similarly to the proposal to be considered on smoking cessation, we recognize that tobacco nicotine is an addictive drug. And individuals that are smokers can be participating in a smoking cessation program and receive the reduction whether or not they actually stop smoking. Thank you for that question.
Thanks, Paul, for participating.
So we have two questions. The discussion of which benefits are supplemental is expected to take place when the board is considering essential health benefits. And what does the term pediatric include? Does it include age 0? If so, pregnant women, is that included?
No, pregnant women are not included in pediatric.
And the issues, go ahead, please.
And I'm not sure what the upper limit is on pediatric or pediatric dental. I think that's going to be decided as part of the essential health benefits statute.
And the issue, though, on supplemental, and it's an important one, we often talk about supplemental. Essential health benefits includes, for instance, pediatric dental, pediatric vision. That is part of essential health benefits.
That's not supplemental.
Generally, when we speak about supplemental in exchange parlance, that is a supplement to essential health benefits, which in this case would be a buyout that would be offered that individuals enrolling in the exchange could choose to exercise a buyout ability for. So those issues are ones that we would actually be looking at. Okay? Okay, we're going to go to, we have a couple people raise their hands. Let's go to Tim Madden if he's available to speak. Tim, are you out there?
Yes, thanks, Peter. Thanks for taking my call. So I had a question on the out-of-network caps, and can you just expand a little bit on how it sounds like you're going to just encourage the plans to try and establish a fee schedule with the providers, so it's not going to necessarily be a requirement for the qualified health plans, or can you just, and our firm represents emergency physicians, so we're in somewhat of a unique position where we have a fair amount of out-of-network situations that occur both with HMOs as well as PPOs. So our folks are just curious how that's going to be handled.
It's a great question, Tim. Thank you. And this is one of the things that Tim's asking a question about something that actually wasn't covered in the high levels of the PowerPoints, but is noting that there's a lot in these. And I think Diana's point is it's complex. It raises lots of issues. And I appreciate your reading with care and raising some questions. So the concept of how might the exchange have positive effects on exchange enrollees that do get out-of-network care. Right now, getting out-of-network care is often the case. You have no idea what you might be charged. It could be, 500% of Medicare. It could be 10 times what you'd be charged in network, et cetera. The concept of recognizing that healthcare costs are healthcare costs to all of us, the concept was to have plans say that as part of their contracting, because again, the exchange does not contract with providers, our health plans do, but to have as part of plans contracting, to have providers agree that for out-of-network care they deliver to enrollees in other exchange plans, not in the one that they have a contract with, they would not charge more than, for instance, 200% of Medicare. And so it would be through the contracting process of plans with providers to affect those providers' rates for out-of-network care for other exchange carriers.
And just one caveat, this only applies to PPO plans because emergency room care, as we know, for HMO products it is covered, and the patient cannot be balance billed. That's as a result of the California Supreme Court case. And the plans and the doctors have to work that out. It's with respect to non-network services, on out-of-network services on PPOs where this becomes an issue.
Okay. So we've got, now this is where we have the embarrassment of riches of a number of comments as we've come to the last few minutes of our time. And actually, so before I try to answer the questions we can't answer all of in the last few minutes, I want to see if either, and I'm not trying to put them on the spot, but Paul Fear or Diana have any other questions or comments from them, and they might text us that I think they do not. But
Paul has to sign off.
Okay.
Good, Peter. Yeah, I don't have anything to add. Thank you.
Great. Thank you very much, Diana. I really want to thank also Paul for having been able to join us for this time. And I want to remind everyone on the phone that every one of the 5 board members will be on some of these calls today or the next 2. And actually, in this last minute, we are not going to be able to answer the questions. We will see if we can respond to people by email, but your questions themselves inform us. And I'd really like Andrea just to remind folks about the next 2 webinars we have coming up, and then we're going to be wrapping up. So because again, this has been a very rich set of questions, comments. We hope it'll inform you to provide better thoughts, guidance, input to the board. And we have 2 more webinars coming up. And Andrea, can you remind us on what those are?
On Thursday from 4:30 to 6, we're going to be talking about provider network issues, adequacy, network adequacy, and essential community providers. I encourage you to sign up for those if you want to give us your feedback on provider network issues. And on August 1st from 8:30 in the morning till 10 in the morning, we'll be looking at a range of issues related to quality and affordability of qualified health plans.
And I'll note that with regard to that August 1st one of the issues we look forward to being able to post to provide access to is the evaluate request for information. One of the things we are considering doing is requiring that plans complete that. I would note in particular that embedded in it are HEDIS and CAPS data points, which are very often collected as part of accreditation, but also part of other processes, but also are some modules particularly related to disparities and diversity issues and issues of payment for medical homes and primary care that we think hold a lot of promise and that are very much worth our looking at. We will send an update to all those who have registered for that call with a link to that information on where you can find that evaluate tool to look at and kick the tires of, so to speak. With that, we are at 6 o'clock. It's been, again, thank you very much to our board members who have joined us. Thank you, Andrea and the team at PwC, which have really been doing yeoman's or yo-person's work in a very tight time frame. And thank all of you for taking time out of your busy days. We need your help. We need your input. We are moving quickly. We have to move quickly, but we also want to move thoughtfully and deliberatively as we move ahead. So thank you all very much. We look forward to many of you joining us in the next webinars and or seeing you at our forthcoming board meeting in August. Thank you all very much.